My name is Dr. Amritej Singh Diol, and we will be discussing gout or cellulitis. What came first, the chicken or the egg? Introduction. Gout is a deposition of monosodium urate crystals in an intra-articular joint resulting in inflammation and joint destruction. Common signs and symptoms are fever, malaise, chills, and severe pain, especially occurring in the first metatarsophalangeal joint. Gout may be due to hyperuricemia from either excessive urate production or decreased uric acid excretion from the kidneys. The diagnosis is confirmed with arthrocentesis revealing needle-shaped, negatively birefringent crystals in the synovial fluid and uric acid crystals, which we can see in Figure 1. Treatment typically is with colchicine, NSAIDs, or corticosteroids and uric acid reduction. Cellulitis, on the other hand, is a unilateral infection of the dermis and subcutaneous tissue that occurs after disruption of skin and inoculation of surface bacteria. Cellulitis presents as warm, raised, erythematous, and tender skin. Diagnosis is clinical, but workup may include cultures, routine labs, and imaging. Antibiotics are typically needed for cellulitis. We illustrate a case of atypical presentation of gout that was confounded by a superimposed cellulitis. Case presentation. Our 67-year-old man, prior to coming to the emergency department, had been fishing in the river barefoot and scraped his dorsolateral foot. He showed up to the outpatient clinic and was given oral antibiotics and was told to return if symptoms persisted. The man presented to the emergency department with pain in his right foot, made worse with movement, and improved with elevation. His past medical history was significant for coronary artery disease, hyperlipidemia, and obesity. The right dorsolateral foot was warm, swollen, and tender to palpation over the lateral ankle. He was diagnosed with cellulitis and given IV antibiotics, Zosyn and vancomycin. The pain and swelling got worse, and an orthopedic consult was obtained. Aspiration of the right ankle was done, and synovial fluid analysis was positive for uric acid crystals and leukocytosis. This patient was diagnosed with gout and started on steroids. The patient started improving and was discharged home on antibiotics and steroids. Discussion. While cellulitis is typically diagnosed clinically and managed with antibiotics, persistent symptoms of redness, swelling, and pain should raise concern for a different etiology. If routine labs, imaging, and cultures remain inconclusive, arthrocentesis of the joint should be done. If the synovial fluid is positive for uric acid crystals, appropriate treatment for gout can be started, including steroids. Almost 80% of gout occurs in the first metatarsophalangeal joint, big toe, and unusual presentations are seldomly reported. If the symptoms persist despite appropriate therapy, physicians should consider other underlying diseases. An underlying gout condition can make a simple cellulitis infection very difficult to treat and manage. Conclusion. Even the most conscientious physicians can be faced with the dilemma of missing an atypical presentation of gout. For this reason, differential diagnosis of gout including cellulitis, septic arthritis, underlying stress fracture, rheumatoid arthritis, psoriatic arthritis, and pseudogout should be kept in mind by all treating physicians. Thank you.